Welcome to the Dr. Mama Says podcast, where you will hear a variety of timeless tips on parenting and healthcare. Thank you so much for joining today, and now it's time to get on with the show.
Hey there, everyone. I'm Dr. Burton, the host and creator of the Dr. Mama Says podcast. Thanks so much for choosing to join me again today. All right, on this episode of the podcast, I want to try to discuss some of the reasons why that stuffy nose in your newborn may actually end up being life-threatening. Newborn babies have irregular breathing patterns for lots of different reasons, and parents are often concerned about something called noisy breathing. These breathing problems can happen from lots of different areas in the airway, but the most common place is the nose. Although nasal congestion is common of people in all ages, newborn nasal congestion may indeed be life-threatening. First, I want to clear up something. Nasal congestion has different degrees, and the most severe form is called obstruction. So I could have gone ahead and called this post nasal obstruction, but that just sounds a little too ugly. So let's just stick with nasal congestion and understand I'm talking about the severe and life-threatening episodes. All right, so why do newborns have so much trouble breathing? As I said, there are many different parts of the respiratory tract that can lead to trouble breathing, and infants have several things that can all work together to lead to breathing problems. Some of them is they breathe more through their nose and their mouth. Their breathing pathways are smaller and easier to block up. Their chest wall is also more flexible because there's more cartilage than there is bone, and it's easy to collapse. Their muscles are also immature, they're weak, and they get tired early, and their lungs and airway can often be swollen just because they've been swimming around in that amniotic fluid. So when you add all these together, noisy breathing is common. But please understand that physicians look for symptoms other than I hear some noise. For instance, the type of noise matters. I will never, ever be able to beat this drum enough, but the drum is parents need to know the history of the problem. Besides saying I hear a noise, it's important for you to be able to say, and what is that noise doing? Is there trouble sleeping or eating? Is there some problem that noise is causing? Every parent wants things just to go away, but many times the things that we can offer are worse than the problem itself. So every visit, when you as a parent discuss a problem, we weigh the risks of us doing something versus watching to see if the problem will resolve on its own. In fact, I have had ugly, negative online reviews because of these problems. Parents come in, they report a noise. It's not present in my office. There's no associated problems. There's no coughing, eating well, gaining weight, sleeping well. I try to make it happen in the office so I can hear it, but nothing. The child is sleeping. I don't hear the noise. We wake him up, sit up. There's no noise. I irritate the baby. Yeah, I can get pretty good at irritating a baby. Baby's crying, still no noise. So I think this is a good thing. And I'm saying, well, whatever the noise is, it may come and go, but it's not present today. The frustrated parents look at me and go, but it's there. It's going to come back when we leave. When a physician is reassuring you in the office, that is important. We are doing an evaluation. I don't have to order fancy tests and x-rays. I need to have some symptoms to help me to know where to go. But after I finish reassuring, parents will leave and write a negative review and say that they paid an expensive specialist copay and I didn't do anything. But indeed, I did do something. It just wasn't the something that you were expecting. In fact, you should have been upset with me for ordering a CAT scan on a baby that had no symptoms. But let's put that aside. I think one of the main issues is that a lot of times when infants have trouble, it happens on the weekends or at night, and it can be scary to parents, so they go to the urgent care or the emergency room, and when nothing is seen there, they're often referred to ENT. And I understand that these things can happen off and on. I need to know the pattern, and this is why I cannot stress enough the value of having a primary care physician. These physicians can notice this hasn't gotten better, or it does come or go, or there is a consequence. Having insurance that allows you just to go to whatever specialist you want, it's fine and it's freeing for you. However, coming in for me to check it out may not give you the results that you're looking for. I'm happy to do it. You're welcome to come, but keep in mind, these are the questions that I'm going to want to know because all the problems that I'm going to talk about require me to be more invasive, and I need a reason to be that way. All right, so in general, what kinds of problems are we talking about where the newborn has this severe nasal congestion? As with most medical problems, physicians look at problems in different categories, such as congenital. Of course, that's the most common one we think about in a newborn, something you're born with. Infections, trauma or injuries, medications or chemicals, and of course, tumors. Tumors are something everybody always thinks about, and when you hear the word tumor, people think cancer. That is generally low, low, low on the list. Of course, there can always be cancer. It's just extremely rare in a newborn. Newborn nasal obstruction can range from very mild to life-threatening. Sometimes when congestion is not found for several weeks, it's because the problem needs time to evolve. We need to see the symptoms and the consistency of it. Over time, the impact of the trouble breathing can lead to trouble eating, trouble sleeping, poor weight gain, failure to thrive. These are all important factors that say this is not just noisy breathing. This is having an impact on child development. So how do we go about managing the stuffy nose in the newborn? As I mentioned, infants breathe out of their nose more than their mouth. Essentially, until they're 3 or 4 months old, most infants cannot breathe out of their mouth. Mouth breathing tends to be a learned behavior for most kids. I've found many infants are what we call obligate nasal breathers, meaning they will not open their mouths to breathe and bypass that stuffy nose unless they're crying. So constant crying in a newborn could be them telling us that they're having trouble breathing. So here you go. Let's talk about 10 of the potentially life-threatening causes of newborn nasal congestion. And when I say newborn, I mean a baby less than 6 weeks old. At 3 to 4 months, yes, that infant may have significant congestion, but it tends to not be as severe as these potential life-threatening causes I'm going to talk about. Each of these problems is going to have a different set of symptoms, and physicians will use their history and exam to determine what step to do next. Often this involves seeing an ENT physician who may perform a nasal endoscopy with a telescope in the nose, or a CT scan or an MRI may be needed. Neonatal rhinitis. All right, rhinitis means inflammation of the nose. So lots of different things can cause inflammation of the nose. So allergic rhinitis, that's the classic allergy. So I'm talking about something in a newborn where they've got rhinitis. This is not an allergy. This problem is felt to be due to high hormones from the mother transferred to the baby, kind of like rhinitis of pregnancy. Many moms know how stuffy their noses were during the last part of their pregnancy. It can be awful. So when those hormones are raging, some of the tissues in the nose are really stuffy. But when a baby is born this way, they can have life-threatening upper airway obstruction because their nose is completely blocked by these swollen tissues and they are constantly crying to get their air in there. Even though this is a fairly common problem, there's not been a lot of scientific research about it. Usually the diagnosis is made when afrin drops are placed into the nose and the breathing improves. Many times an ENT physician will then use a flexible scope to make sure that there are no structural problems. Other ENTs don't want to put a telescope in there because they want to wait for some of the swelling to go down and they don't want to touch in there and make the swelling get worse. I personally like to know all the facts up front. If I see an infant with significant nasal obstruction, I will use a telescope after the afrin because you can have more than one problem. What's the ultimate treatment of this? Some physicians use afrin for 3 days. Afrin is an awesome medication. However, it's addictive. So after 3 days, you have to stop. And I have found that in these newborns, they have a higher relapse rate. So I always treated these with steroid drops. Often they're eye drops, and I use them for up to a week, and I consider them kind of the infant version of using Flonase in your nose. Let me take this opportunity to emphasize the importance of not using afrin more than 3 days. To avoid the temptation, I tell parents to throw it away. Having afrin in your medicine cabinet, you are going to be tempted to use it. Babies struggling at 3 a.m., trouble breathing, you will pull out that afrin. But using that afrin gave you temporary relief, it can lead to long-term nasal problems that are harder to control. So don't do it. If babies keeps getting stuffy, come on back. Let's find out what else we need to do. The next category is called choanal atresia. All these are going to be kind of big words. You can go to the show notes and look up the problems individually if you like. But the choanal atresia is one of the most common nasal birth defects. Instead of the back of the nose opening into an area that drains into the throat, there is some cartilage or bone that blocks one or both nostrils. The most severe type is when both nostrils are blocked and the baby can only breathe when they open their mouth and cry. They often have a bluish skin coloration and they have a dangerous lack of oxygen. This is the life-threatening emergency everybody thinks about in a newborn who has trouble breathing. The diagnosis is often made in the delivery room when a physician or nurse is unable to pass tubes or suction catheters into the nostrils. Infants that have blockage only on one side or that are narrowed and not totally blocked are often able to be stabilized, let them grow before surgery is required. However, when both sides are blocked, this can be the surgical emergency. They often need to have either a long-term tube placed into their nose or into their mouth, and then surgery is done through the nose using telescopes to open up the airway. There tends to be an increased risk of recurrent surgery needed because you're doing surgery in a circle and the healing wants to scar back down in the circle. The next blockage that can be formed in a newborn at birth is called piriform aperture stenosis. Big old word, but the piriform aperture is that hole. When you look at a skull and you see that big old hole in the middle of the nose, that's the piriform aperture. And that tends to be the most narrow part of the airway. So when the bone is too narrow right at this bony part of the skull, it's very difficult for air to get into the nose. And at birth, when the suction catheter is trying to be passed, it's unable to get into the nose. Whereas in choanal atresia, it gets into the nose, but it can't pass into the back of the throat. Most of the time, these problems are mild and kids will outgrow them. However, if it's on both sides and severe, surgery may be required at a very young age. Often this may be done by making a cut underneath the lip and going up to the skull face and drilling down or removing some of the extra bone that is narrowing the opening into the nose. Trauma is another thing that can happen in kids. Now you think about a newborn with trauma. Well, when babies are born, that birthing process can be very hard. Uterine contractions moving that baby throughout that birth canal, especially if the baby is sunny side up. That means the face is up. Usually babies are born with their face down, facing backwards, but when babies are born with their face up, they tend to have a longer birth process. Sometimes medications are needed to have stronger uterine contractions to push the baby out. Plus, there's often a greater need to use forceps or other assistance to help pull the baby out. There's more potential for facial trauma. Sometimes these babies have a deviated septum. The septum is the part of the nose that divides the nostrils into two even pathways. Most of the time, the deviated septum is mild. However, if the septum is moved completely to the other side, has a complete dislocation, surgery is often required to move it back to the midline. I do recall back in my residency days having to go to the ICU for these newborns whose nose was very deformed. The nose was pushed to the other side. Usually it's not that severe, but if forceps or twisting or any other things happen, when you see all that swelling in a deformed nose, baby struggling to breathe, doing a nasal reduction, trying to move that cartilage back to the midline can definitely be a way to improve the baby's breathing. Again, not often needed. Most of the time as baby grows and the face starts to develop, the deviation is not that big of a deal. Another type of trauma can happen with a septal hematoma, meaning a collection of blood occurs between the lining of the nose and the septal cartilage or bone. So with an injury, a blood vessel breaks, a blood collection forms, and it can block the nose and the infant has trouble breathing. Well, when the child is evaluated, yes, all the catheters are passed through the nose, but using a telescope, you will see that the swelling is in the middle part of the nose and a septal hematoma. That diagnosis needs to be made because that treatment is simply making a cut in the lining of the nose and draining out the blood so the airway can be more open. Reflux rhinitis is when gastric reflux is causing an irritation and swelling of the nose. I'm sure a lot of people have heard the phrase, all babies spit up. Well, there's a difference between spitting up and having reflux. Like all medical problems, it depends on the severity, the frequency, and complications. When stomach acid repeatedly travels up the esophagus, it lands on tissues that are not made to handle that harsh acid. When it happens chronically or recurrently, it can then be diagnosed as gastroesophageal reflux. So besides regular stomach symptoms, many people with gastric reflux have upper airway problems, which is why ENT physicians often end up seeing and treating these patients. When infants throw up, have you ever noticed how sometimes they throw up and it comes out of their nose? Yep, that acid can burn that nasal lining, leading to swelling and obstruction. I've also seen bad refluxing babies who have recurrent nosebleeds. So stuffy noses in newborns struggling to breathe. If we're not finding a physical obstruction and we see swelling, yes, we think about the neonatal rhinitis, but we also want to keep in mind potentially this could be acid reflux. Nasal infections can also cause difficulty breathing in these newborns. Obviously, the most common infection is a cold or a viral infection, and usually you can tell something besides just a stuffy nose. But remember, infants are born with sinuses. And if their congestion persists for more than a few weeks, sinus infections may also need to be considered. Not common, but need to be considered. And of course, let's be honest, any infection that mom has during pregnancy can be passed on to baby. Some are transmitted through the blood, but some are obtained directly through the birth canal. Whenever a newborn has a stuffy nose or a runny nose, a culture of the nasal discharge may be needed. Just saying, gotta keep it in mind. A tear duct cyst can also happen that blocks the nose. Why is that? Well, you ever notice when you cry, your nose starts to run because the tears can drain into the nose? Well, there are kids that have a narrow tear duct and the tears tend to linger around their eyes. If the blockage doesn't allow the tears to collect in the eyes, it can form and make a cyst partway through that tear duct and it can bulge into the nose. If it happens on both sides of the nose, it can have life-threatening airway obstruction. This can be seen by putting the telescope in the nose and seeing the swelling coming in from the sides, confirmed with a CAT scan. Treatment is often with surgery using telescopes to open up the cysts and allow drainage to happen. Unusual craniofacial development is obviously a cause of nasal obstruction. When the bones of the skull don't form properly, they can lead to narrowing of the face and the nose. These are often evaluated with a variety of CT scans and MRIs as well as telescopes. Some of the more severe forms require the infants to actually have a tracheotomy placed as a hole in the neck to allow for breathing, because these malformations can take a long time and serial or repeated surgeries to repair them. Brain cysts or mass are something that parents don't often think about, but most physicians think about in a newborn. If you think about the anatomy of the nose, the top part of the nose sits under the bottom of the brain. So if the bone doesn't form well, the tissue or fluid surrounding the brain can bulge down into the nose. And if it's just the tissue and the fluid around the brain, this tissue is called the meninges, and when it gets infected, it gives us meningitis. But when fluid collects and it bulges down into the nose, it's called a meningocele. If the bony defect is large enough, some of the actual brain with the tissues comes into the nose, and that's called an encephalocele. Sometimes just a piece of brain tissue can be located in the nose and there is no actual connection to the rest of the brain. This is called a glioma. These masses are the reasons why it's important to never just go biopsy a mass in the child's nose without a CT scan, MRI, or a nasal endoscopy. Usually brain cysts and masses occur on one side, and these problems are managed with surgery using telescopes, but sometimes if the hole is big enough, a combination of an ENT surgeon and a neurosurgeon may be needed. And the last category of severe newborn nasal congestion occurs from nasal tumors. And of course, this is what most parents are concerned about. But these are rare. At birth, the most common tumors are called teratomas, and these are made from different tissues from a variety of different parts of the body. Usually they require surgery to remove them, but often not life-threatening. Dermoids are tumors that occur when skin cells get trapped within the nasal bones during development. Skin is always supposed to be on the outside of the body so that it can shed. So when skin is trapped inside the body, bad things can happen. I talked about this briefly when I talked about ear infections and complications from ear tubes when skin from the eardrum grows inside the body. Skin in the wrong place always causes an issue. Hemangiomas are groups of blood vessels that can collect and make a mass. And of course, malignant tumors can happen. Again, very rare. So in a newborn, that's not high on our list. Well, alrighty now. Big old list we just talked about, but this looks like a good place to wrap up. For now, I gotta go. Hope you come back and check out another episode soon.
I truly want to thank you for spending your time listening to Dr. Mama Says, because without you, there would be no podcast. If you enjoyed what you heard, please go to iTunes and consider leaving a 5-star rating. This will help gain the support needed to continue bringing new and exciting content. To review information presented in this episode, a summary of the show can be found on www.drmamasays.com. And don't forget to subscribe. Hope you come back and listen again soon.